Great, thanks so much. Well, good afternoon, and thanks for hanging in for the last panel. I really appreciate it, and really the opportunity to be here today. It's been really exciting for me personally as a clinician to see the array of technologies that have been described all throughout the day, both things that are in existence and in development. And as a geriatrician and someone who cares deeply about improving the quality of care for older adults, my question always is, well, how do we fit in this technology? Where and how does it fit in? And does it make a favorable impact? And for me, when I think about the patients that I care for, and in my previous role in academia and caring for patients, it's, are we improving the quality of life, the patient, the consumer experience, and again, favorably impacting outcomes? So are we stabilizing the course of a disease in the short or long term? Are we preventing hospitalizations and emergency department visits and rehospitalizations, those things that are of concern to everyone as a patient or consumer, but also to the healthcare system as a whole from the quality and cost perspective. So my task is somewhat hard in terms of talking about health monitoring in a very short period of time. So what I'm going to do is set the stage a little bit and then give a couple of practical real-world examples of health monitoring and some use of technology in an older adult population that we've tried within Aetna Medicare. So try to give you some data and experience and share with you some of the pros and cons of what we've learned and really the lessons to inform us as we incorporate technology or see where we can incorporate technology. As has been already mentioned here today, no surprise, I'm always thinking about a Medicare population because that's the world I deal with right now. And our average patient population is 75 years old, and as has already been mentioned, a significant number of them, and the new normal really is for people to have more than one chronic condition. So in fact, as you can see on this slide at the very top, about 20% of the population that we deal with has 5 or more different chronic conditions. Obviously, they're costly, and we focus a lot on them and trying to improve the quality of care that they receive. But certainly the people who have 2, 3, and 4 chronic conditions also have a lot of care management needs, and we have a lot of tremendous opportunity to intervene and to try to help them wherever they are in the disease trajectory or the chronic condition trajectory. So just to set the context, when I think about geriatric care management, and in particular within the health plan, just to level set, we have a lot of dedicated teams traditionally of registered nurse case managers, hundreds of them who try to reach out and engage patients, mostly telephonically, but increasingly on the ground, embedded, working with local providers side by side to try to favorably impact outcomes for older adults. We're dealing with a wide variety and a spectrum around the circle, if you follow me along here. So we have people who are just trying to stay healthy. That's probably the minority of people who are already well, and that we have wellness and prevention programs that we're targeting to try to maintain their health. The majority, as we say, are in this green box here managing a chronic disease. So they have one or more different chronic conditions, and we are trying to match tools, resources, benefits, care management programs to impact favorably their health outcomes if we can. They're managing risk and health risk factors along the way that they start to acquire. Many of them have major health events, as you can see if you follow around on this circle. They have an acute episode of care, so that could be a stroke that brings them into the hospital or an exacerbation of a chronic condition, COPD or congestive heart failure. Those are the people, obviously, that a lot of resources are devoted to also because they're actively within the healthcare system, and there are a lot of care coordination needs and care management needs pre- and post-hospitalization to allow them to make the safest transitions from home to hospital, skilled nursing facility, or rehab, and hopefully back to home. When we're talking about health monitoring, I know we're talking about technology here, but it begins with a basic premise of understanding basic information about people. One of the things within Medicare plans that we do is a health risk assessment, hopefully on everyone, and we usually get the vast majority of people when they're first aging into Medicare or joining a Medicare plan to complete a health risk assessment. So that doesn't require a lot of technology, but it's basic information and data about someone's health status, functional status, self-reported chronic conditions, so that we can proactively try to intervene and again align resources early in the process to those people who have chronic conditions or functional status needs that could be addressed versus waiting until he or she is hospitalized. So we do a lot of that background work before waiting for acute episodes of care to happen and then trying to intervene. So let me talk a little bit about health monitoring technology and a couple of specific examples. We can use health monitoring and technology on the left side of the screen for relatively healthy. I'm not going to focus there, but I'm going to give two examples more on the right side of the screen. People who have risk factors and early stage chronic disease, what can we do there? And then complex medical needs, for example, congestive heart failure or chronic obstructive pulmonary disease. So the first example is using interactive voice response. So this is not the highest of high touch for some of the things that we've described today, but I want to give this as an example of incorporating some technology into an aging population to manage a highly prevalent condition. So high blood pressure, about 2/3 of us will ultimately, when we reach Medicare age, probably be diagnosed with high blood pressure, so it's phenomenally high. About 50%, if you look at the national data, of people are inadequately or suboptimally managed. So an astounding array of people, despite the presence of antihypertensive medications and good interventions, are not receiving optimal care. What can we do about that in a scalable way that really reaches out and tries to engage people? Well, we can use an interactive voice response technology to try to engage them. So what we've done is voluntarily invite people who have high blood pressure to receive a free automated blood pressure cuff. It orally tells you your blood pressure when you put it on and your heart rate, and obviously visually tells you your blood pressure. So these are sent out to folks. They're asked to record their blood pressures over time, and they receive regular automated phone calls to enter their blood pressure. They have a series of interactive questions they answer, but they also punch in their exact blood pressure on the phone. They also receive supplementary educational mailings about health education, hypertension, things that go along with hypertension like hyperlipidemia and other screening type education. If someone's out of range when they enter their blood pressure, then they get immediate feedback. If they're within range, they get education that they're within an appropriate range. And we match resources if people are within an abnormal parameter so that they get a live nurse case manager outreaching to them if they're out of range. So you get that live component in a scalable way to reach out to them. And really the goal, as is mentioned on the slide, is really to encourage self-management over time. So people we want them to participate not for a month, but for a year to gather that data and to learn about their blood pressure. And as they're entering it, actually acknowledge and learn about the range of blood pressure if they're capable of doing that. So what do we find? Well, we find on a population basis, first of all, that you can statistically significantly reduce systolic and diastolic blood pressure across a population if you engage enough people. And that's what we found on average. Importantly, on the first bullet on the slide, about 18% of people who started in the program at the beginning moved from out of control blood pressure to in control by the end of the study. So that's pretty good in terms of affecting positive intermediate health outcomes. There was an increase in the rate of screenings around cholesterol, because they did get some education about that also. The majority of them said they knew more about their blood pressure if they participated in the program. And when we did some health economic modeling, we assumed a low participation rate, but I won't read all the numbers, but the real obvious favorable outcome is averting heart attack and stroke, for which hypertension is the greatest risk factor.
What do you mean by the 8% participate? What does participation mean?
Yeah, so someone who signed up for the program, got a blood pressure cuff, and started entering their blood pressures when they received these calls. At least they entered 2 blood pressures. So we modeled it originally on 8% participation. We're running probably 2 to 3 times that amount of voluntary participation now. So over 20% of all people with hypertension are saying, yes, I'll participate in the program, and actually do start participating. So actually much more than we anticipated, and should be correlated over the long term with better results. So there are short-term results for this, better blood pressure control, hopefully, for a reasonable number of people, and then the long-term results, which haven't been measured yet, because we need more years, obviously, to measure outcomes, hard outcomes of heart attack and
Could
stroke.
I also ask a clarifying question?
Yes, please.
When you say, you kind of gave a little demonstration of they just punch in the numbers on the
Yeah,
phone.
yeah.
Trust me, there's nothing about just punching in numbers on the phone when you have arthritis or an intention tremor or something like that. So is there a voice activated option so they don't have to just punch in the numbers where some software tries to recognize a voice?
There
Or
wasn't in this version, but that it's capable because it's interactive voice response. Our first thought was that if people actually enter the number, they'll know it, but obviously there are limitations for people who may not be able visually or functionally be able to do that. So completely understand, and I think it's one of the things we want to take into account. How can you get more people to participate as actively as possible? The other option, of course, is to do this wirelessly, and we can talk about that. Which has pros and cons also because people don't pay attention as much from focus groups. If you look at if the information just gets fed and they don't really see what their blood pressure is. So there are certain trade-offs. But let me go over a couple of the barriers and then opportunities that we saw with this. I think adherence rates, and not many people have talked about this through today that I heard, but over time, adherence wanes for a lot of different interventions, and this is one, for example, that adherence can wane also. But I think it's similar to almost any technology we talk about. If you're asking people to do something or interact, then they may drop off in their adherence rate over time. There's certainly a degree of acceptability or non-acceptability of not interacting with a live person. So that's certainly a barrier for many people that needs to be overcome or may not be able to be overcome if you're having these automatic calls. The personalization aspect, I think, is also key. We traditionally deal with live nurse case managers who reach out. They're all trained in motivational interviewing and really can respond in a thoughtful way and understand what motivates people to make health behavior changes. You can't do that as reasonably well, obviously, with an IVR system. The opportunities and facilitators, just a couple to list, are that I think the acceptance, I'm calling this more low technology because it's not as fancy as some other biomonitoring that I'll share in the next example, but there's a very practical aspect, as was mentioned just earlier, about who has internet access and connectivity. And when we look at our 75 to 85-year-old patients who are participating in this program, there are a significant number who just would not have internet access. So the phone mechanism is much more scalable in that sense. Obviously, all the caveats that we mentioned before, things may change over time, and if we could get out more connectivity to people, then there would be that opportunity. Scalability, I just mentioned. The cost efficiency of doing automatic calls should be clear to many of you. And the live nurse case management backup, I think an integral component, as someone had mentioned earlier today, was there's still a high-touch patient component. Like if people are out of range, they need advice, guidance on what to do if they're not sure. This is a way to make it a bit more efficient so that we can have a ratio of how many people really trigger for out of blood pressure or need help, and then again match them with a live nurse. I would say one other thing, we've tried this with other conditions, and we've piloted it with, for example, diabetes, and there are pros and cons for every different condition, and we've only tried several so far, but diabetes is another chronic condition for which you need chronic self-management. And we've done this trying to collect blood sugars, blood glucoses over people to allow them to maintain better control over time. And the acceptability of an intense management where you get a call or interact and input much more data on a very frequent basis leads to lower adherence rates too, because people trail off with some of these interventions. Second example, health monitoring. This is a more higher technology example, would be biometric monitoring for congestive heart failure. So congestive heart failure, #1 cause for readmissions to the hospital. It's on lists of any chronic condition that most of us are looking at to try to improve the quality of care, because many of those admissions to the hospital are avoidable with high quality care management. Here, the objective was to install a device in the home that would allow for blood pressure and weight management and other biometrics as needed in people who are at high risk, who have congestive heart failure, who may be admitted to the hospital. Randomized to having a case manager or having a case manager expert in CHF plus this technology. And after 6 months, looking at a primary outcome, a combined outcome of all-cause hospitalization, emergency room visit, department visit, or death, there was no significant impact for this particular intervention. And we don't have time to go into all the hypotheses on why that may be, but certainly the case managers alone do a very good job when they reach out, identifying what are some of the appropriate triggers. What we did find was that the telehealth technology really prompted a lot more calls to address some of the triggers and the data that was being collected. And managing that workload is not always easy, so triaging all the data that's coming in. So as everyone has mentioned earlier, data and information, turning that data into information that's reasonable and actionable for nurses and other healthcare professionals is really key. Someone has to interpret that, or an algorithm has to interpret that.
So what was the primary composite outcome?
It was the three listed: hospitalization, ER visit, or death.
And there was no effect on that, but there was a reduction in
There was a
inpatient
reduction in people if they got admitted to the hospital and how long they stayed to the hospital. But really, that's not attributable to the device, because the device is really working in the outpatient setting. That's really attributable to the nurse case manager interacting and doing proactive discharge planning with the healthcare facilities to try to transition people appropriately.
Was the telehealth interactive or just a standard set monitoring?
So this was a download of information back to the health plan. So there wasn't a lot of conferencing back and forth. Obviously, a lot of different types of technology available. There are other studies, I'll say, that are favorable in this regard, and some prominent ones using the same technology that we did that were also negative. A study this year in Archives of Internal Medicine out of Mayo Clinic did the same thing, but not just for heart failure, for older people who have multiple chronic conditions, which you would say, well, that's exactly real life, as I described earlier. That, unfortunately, was also negative in terms of hospitalizations and emergency room visits. The barriers, participation rate is lower when we just actively invite people. If you work through the physician's office and work as a team, people join much more commonly than if the health plan is reaching out saying, will you participate in this program? The device installation, maintenance, support, infrastructure, all of that takes much more time than some people imagine. And whoever's behind that needs to have the support and resources to problem solve, to re-engineer, to maintain the devices. And we found that was much more intense work than anyone anticipated. And I think the biggest barrier is who's most appropriate for these programs. The patient selection, what's the degree of illness severity, what type of condition, where are they on the spectrum, who could benefit the most is not clearly known for many conditions at the moment. And then to summarize briefly the opportunities, clearly there are many types of technology. They're evolving rapidly, they're lower cost, they're more functional over time, and they're easier to use. So we have many companies obviously presenting to us and coming to us saying, you know, this is the latest and greatest device, and it's very hard to sift through what are the newer technologies that really are incrementally better and make a difference. Finally, I would say just the last bullet on this slide, closer collaboration. People working in teams in patient-centered medical homes and accountable care-like organizations are probably moving this forward faster because they're realizing to manage the healthcare of a population, they need to work together. So case managers at a health plan working with the patient and the physician in the community increasingly have common goals to keep people healthy and out of the hospital. So to summarize, I would say that there's tremendous opportunity with technology trying to address an older adult population that has multiple complex and costly conditions that require a lot of care coordination is a challenge for everyone. Really, the technology from a clinical perspective, I would view as a means to an end. It's a tool to really affect the clinical outcomes positively for patients, and not just to install the technology. how do you make people's lives better, their patient experience, the clinical outcomes of keeping them healthy and out of the hospital, and obviously stabilizing their progression, and if we can help it, not increasing the cost of care, which is obviously paramount. Thanks very much.
Thank you. Thank you, Dr. Agostini. Yes, Carolee, please.